Good evening, everyone. Thank you for joining us for this webinar on what the role of GPs play in community palliative care. My name's Jen Francis. I'm the lead for older adults and palliative care projects at Northwestern Melbourne Primary Health Network. And I'm joined by Tien and Wendy from Banksia Palliative Care, who will be speaking this evening. I'd like to start this evening on behalf of Northwestern Melbourne PHN and Banksia with an acknowledgement of country. I'd like to acknowledge the traditional custodians of the land on which the work of both our organisations take place. We recognise the continuing connection to land, waters and culture and pay respects to elders past, present and emerging. I also extend those respects to any Aboriginal and Torres Strait Islander people in the session with us today. Just some housekeeping before we get started. All attendees will stay on mute for the session. If you do have any questions, please use the Q&A box. It just allows us to keep track of the questions a little easier. If you have any other issues or concerns, you can send a message to me in the chat function instead. The session is being recorded. When we ask any questions, if they're read out, they'll be read out anonymously to protect your privacy. Just in terms of attendance and CPD, we do use Zoom's attendee list to mark attendance. So if your display name might vary from the name you registered with, or if you're not sure that it's displaying correctly, please do feel free to send me a message in the chat box just to confirm your name to ensure we can register your attendance and your CPD and attendance details. So that's all the housekeeping. I'd just like to pass over to our speakers. So tonight we have Dr. Tien Lin, a palliative medicine specialist and still practicing GP on Saturdays as well, and Wendy Palmer, the education and development consultant with Banksia Palliative Care. So thank you all for joining us this evening, and I will pass over to Wendy.
Thank you. So welcome everyone. Welcome to What's My Role? Understanding the part GPs play in community palliative care. So we're just going to go through a little bit about Banksia. Banksia Palliative Care is a non-for-profit organisation and the sole state government funded community palliative care service for 3 local government areas of Banyule, Nillumbit and Whittlesea. We provide a 24-hour palliative care service for a population of about 420,000 people over an area of 1,000 square kilometres. And over the last 30 years, Banksia have been providing the no-cost expertise and practical support to children and adults living with a life-limiting illness, supporting them in their home and decreasing their need, hopefully, for hospital visits and stays if that is their wish. We work alongside other healthcare professionals like yourselves, other medical specialists and aged care facilities and local councils, referring to Clark, for example. And as of this week, we are up to about 450 clients, which when I first started was about 250 5 years ago, so it's increasing. The service is doing well. So a snapshot for 2022 in the way of numbers, we received just over 1,000 referrals, and they can be done via themselves or a relative or friend, or by GPs and other health specialists. Aged care facilities also, we get quite a few numbers from aged care facilities, hospitals, inpatient, acute and PAL care services. The admissions, we completed about 855 admissions, and not all of those end up using our service. So 196 people, all their families did not receive the supports from us, and in the way of non-malignant admissions, there was that 338 and 517 of malignant. there were 748 deaths. 308 of those were in hospital and 440 at home, including residential aged care. So for tonight, we're going to just have a look at who is Banksia, which I've just gone through with you. What is palliative care and how it is delivered, the role of community palliative care, the supports that community palliative care provides. We will have a look at a case study just for more for insight, and interventions, medications and practical supports to enable end-of-life care at home. Have a look at bereavement support, verification and certification of death in the community, and those essential conversations, all those tricky conversations that a lot of people don't really want to have sometimes. So, Jen.
Yes.
Yes.
Hi, everyone. Hope you can hear me well. So thank you, Wendy, for talking through what Banksia is like, and really wherever you live in Melbourne, there's usually a designated community palliative care provider, and similarly will provide very similar services to support people to live in, die at home if that's their preference. So the key about palliative care is that it is person-centered and family-centered, and because people generally, when they're living with dying, they have increasing amounts of debilities, and they do need care, and most of that comes from the family. And thank you. Basically, that's the message anyway. It does not equal to no care. So essentially, continuing care, even in fact, providing more care when we're not able to treat the disease is essentially the message, because people often look at it as giving up, but it's not. It is important to keep people. Is it on auto mode or something? Or?
Oh no, sorry. Am I? No, it's not. It's just me.
Okay, no problem. Just double check. Yeah, that's fine. Yes, keep me on my toes. And certainly aims to enhance quality of life and help people live as actively as possible. It does regard dying as a normal process, and make sure there's relief for pain and other symptoms if present, and intends neither to hasten nor postpone death, and integrate psychosocial and spiritual aspects of care or of life, really, and uses a team approach to address the needs of patients and their families. Also offers a support system to help the family cope with during the patient's illness and in bereavement. Yeah. So everyone may need palliative care, and chances are will benefit from for a period of time in the modern society where and it's saying palliative care because we include bereavement care. So even if it was very sudden and short, and the family, in fact, often needs even more follow-up to check in how they're going. And but classically, in Victorian society, we're looking at chronic diseases, including cancer, neurological conditions, in organ diseases, dementia, and inherited metabolic disorders. So in terms of who provides palliative care, there's that debate between generalist and specialist palliative care, but really it is everyone's business, and we all need to be involved. And the key really is to make sure the care continues, even when we can't fix the problem. So all disciplines are needed, and general practitioners really remain the biggest provider of medical care in the palliative care space. even when there's a specialist palliative care service involved. So by specialist palliative care, it's defined by, it's defined more on the service level, that they are people with specialized skills and experience, and are involved in training people to provide care for complex needs. And really, it's not a exclusive setup, in that specialists are not set up to take over care. It is more a shared care setup, where we involve the current care providers, and provide additional experience and additional input where support is required. So it's not like, referring to a surgery. It's more in addition to the current care setup. So where is palliative care provided? Anywhere people want to live, basically. And which is why, yes, sometimes there's nowhere else that can meet the care needs and symptom management needs outside of hospital. But more often than not, if possible, we try to deliver everything at home or in their supported facilities. So now to focus on the community. So why focus on this? Basically, if we ask people, and we have, and the biggest one is in 2013 in a systematic review, in that collating over 10,000 people into 200 studies, that most people want to stay home. And that is understandable. If we're not able to treat the problem, then most people don't want to go back to the hospital. It's not designed for people to live. And in Australian studies, there is a South Australian study that had more than 2,500 respondents, that asking people if they have terminal illness such as cancer and emphysema, also 70% wants to stay home. Whereas in reality, of course, a lot of the time that may not be possible. And only back in 2021, only 14.8% actually occurred at home. And there are, of course, many reasons for that, but it is also important to make sure we support people where possible to maximize their opportunity to remain home. So again, thank you all for your interest in attending today. And hopefully by attending today together with us, we can help improve this number and also overall quality of life and care for our shared patients. So what supports can community palliative care provide? So we have the biggest bulk of providers are our specialist palliative care nurses, and also our social workers. And by specialists, really, this is what they focus on every day. And they're positioned to guide people adjusting and planning for the increasing care needs that's in the upcoming period of time. And we have also occupational therapists to look at their equipment and environmental needs, additional quality of life interventions like a music therapist, a massage therapist. We have volunteers, and also the specialist physicians. And again, this is more a shared care setup, and we're here in addition to their usual care providers and to support the GPs delivering the care. There is access to support 24/7 for the client, the patients and the families. And it's really troubleshooting and try to plan ahead as much as possible. A lot of the time there's no new medical decisions to be made, in that people really should know why they're on the palliative care program. And by the time, and then knowing that, because if we can fix the problem, of course we should fix the problem. That's really, it's really the question is planning the care if the problem can be fixed. So the equipment and social work, adult health input, and respite and support are all important parts to ensure care provision takes over in this very intensive timing. And one of the important draw card is arranging direct admissions to inpatient PCU. And because there's really not much benefit presenting to ED when we already know what's going on. So, so that's one of the important pathways where we don't take up precious time waiting in ED for the patient, really. And they should wait at home, and if they need a bed, and get them in directly.
Thanks, Ken. So, sorry. Yep. We thought we might start with a case study, because that's a good way to just illustrate what happens sometimes with us. So we have Mark here is referred to community palliative care, something marked as urgent, 3 p.m. on a Wednesday, from an aged care case manager. There's no medical information for Mark. The intake, usually we get a referral through, and the intake triages and makes contact with the family or Mark, depending on who the priority contact is. And we find that he's having trouble getting out of bed, only eating and drinking small amounts, has pain, shortness of breath, a cough, and functional decline. He's had recent multiple admissions to hospital, and that often ends up with people get quite annoyed and don't want to do that anymore, and he just wants to remain at home now for end-of-life care. So what we often do is we request medical information from the GP clinic and also the local hospital, and any discharge summaries. Hopefully we can get those as well. So from the medical information we received, we could determine that Mark had end-stage COPD. He had a past history of chronic back pain from a motor vehicle accident 15 years ago, asthma, hyperlipidemia, left total knee replacement, chronic renal failure. He's had 3 admissions to hospital over the past 6 months with chest infections and exacerbation of COPD. Most recent, 2 weeks ago, no discharge summary available, but we do nag for those. Often ringing up the hospital for discharge summaries, or we might even call the GP for a copy for the discharge summary. So his wife, Sarah, has stated that she's very stressed, wanting to keep Mark at home, but concerned that he's now essentially bedbound and increased pain, shortness of breath at rest, which is quite a significant prognostic indicator for end of life, or end-stage respiratory diseases. They have 2 children who both work full-time and have young children, so they're supportive, but they've got their hands full as well. They're quite busy. So initial assessment or admission, what we call would be an admission visit. The nurse would go and visit Mark and the family, or Sarah, at the next available appointment. For this particular day, it was the next day, and he's sitting in his recliner, quite shortness of breath with a moist cough. Minimal oral intake in the past 24 hours, and mainly fluids only. He's still able to take tablets, but becoming more difficult, which is also often an indicator for decline or deterioration. Increasing back pain. He's using oxycodone or endone 5 milligrams 4 times a day, in addition to Tarjan BD. Sarah is struggling to transfer Mark to the toilet and get him out of bed. Mark is aware that he's deteriorating and wanting to remain at home and not return to hospital. So he did see his GP face-to-face 4 months ago and was unable to get to the clinic. Had telehealth appointment 3 weeks ago prior to the recent hospital admission. So things have changed since he's been to his GP. His GP works Monday to Wednesday and is currently receiving a level 2 package providing hygiene 3 times a week and 2 hours respite every 2 weeks. He has seen another GP in the clinic, but they're away on leave. This is a common scenario, especially if people don't link in with their GPs very often. That makes it tricky. So with regards to his medication, he's on the Tarjan BD. And it's stated that he's got an allergy to morphine. And of course, we have to clarify whether that's an allergy or a side effect of the morphine, which, you know, can often be prevented by the antiemetics, but we obviously take that as it could be a possible allergy and avoid it accordingly. He's been on Tarjan for about 6 months and was due to having, and he was having oxycodone, immediate release endone every 4 to 6 hours. Prednisolone had been weaning off from 50 milligrams since discharge from hospital 2 weeks ago. So he's got a few things going on, a few things to consider. So considerations for dying at home is the GP engagement. We always, from a Banksia point of view, we always send a letter once a client is admitted, introducing ourselves, saying, look, we're here, we've now involved, we've been involved with your client's care, and hopefully you're responsible for the death certificate, even though we would do a death verification, but the death certificate relies on the GP. We look at the equipment needs, OT referral if required, access to end-of-life comfort care for medications to manage the symptoms and what we would call SOS medications. If we think that is required sooner rather than later, we would put a request out for that as well. And regular nursing visits to support the family, access to our 24-hour support, our 24-hour phone support, and then if they have those emergency medications in the home and they're needing medication, subcut medication for shortness of breath or nausea or vomiting, then that, an on-call nurse can provide that overnight. There is practical and emotional support for the wife and the family, and then bereavement support for the family post Mark's death. So at Banksia, we offer 13 months post death, just to get over those milestones for the families, and if it's indicated they need longer, then that's obviously assessed accordingly. So follow up after that day of assessment. Mark is clearly deteriorating and likely entering his terminal phase, and he wants to die at home. There are no doctors available at his clinic that have seen Mark in recent times, but one GP had advised that the regular GP who knew him well for many years felt that they would be happy to support end-of-life care at home, and was agreeable to liaise with the community palliative care doctor and provide scripts as appropriate. Swallowing was becoming more difficult, so he was rotated then to a fentanyl patch with liquid breakthroughs, the liquid oxynorm for breakthrough. And then you know, the subcutaneous, what we would call SOS meds, scripted and arranged to be in the home for just in case, for when things, as it continues to deteriorate. Safer Care Victoria website has great resources for information regarding what we would call anticipatory medications, being those injectable medications, you know, for the caring for the dying, and also those opioid conversions and syringe driver compatibilities. It's a great resource. This is very hard to see, but this is like an example of a letter that we would send to our GPs with information about the client and the issues that we're getting confronted with. Here is an example of, we kind of give an example of the syringe driver orders or breakthrough medication orders, and we offer suggestions in the way of doses, but you know, of course, that is assessed on an individual basis. And then, of course, if there is an allergy or a renal impairment, then morphine is not used, and we go usually use the hydromorphone. So that's kind of a recommendation, and sometimes we do get that phone call from the GP just to ensure that, yes, I've got your facts, we've got this information, what is the best dose range? So that it's good to follow up if unsure. And then here's our blank order. That's what ours looks like. But then every palliative care, community palliative care service would have something similar. So when we're looking at the common medications used at the end of life, I mean, they play that integral part in managing symptoms of the life-limiting diseases and optimising comfort, and it is so individual for every person. There's no one person the same. The injectable medications may be required if they can't tolerate oral medications, or if there's absorption issues, and the stress, there's other factors that are causing discomfort. So the most common that we see for the pain is the morphine, hydromorph, and fentanyl. Nausea, for the nausea, it's metoclopramide and haloperidol. Cyclizine, also used at times, depending again on the individual and the assessment as required. Agitation, usually is we use the clonazepam drops, subcutaneous midazolam and haloperidol, and for secretions, the glycopyrrolate, atropine, and hyoscine butyl bromide. So with that does come a bit of anxiety from the family when they see all these weird and wonderful medications coming into the home and they're not quite sure. So we do provide a lot of education regarding these medications, and action plans, and a lot of support. A lot of written and verbal information is provided, because sometimes you would know this yourself, you might advise a family member or the person something, and it just doesn't, you know, they forget about it, and it needs to be explained a few times or written down. So then, and then of course we have the practical information in regard to personal hygiene and bed care. If there's requiring a hospital bed in the home, we would arrange that. And also we have staff that do generalist care to assist with educating the family on how to provide personal hygiene using slide sheets, that mouth care. All of those things that a lot of people don't think of when end-of-life care is at home is more the personal care factors. So we gently introduce those topics with them because it's can be quite more challenging than they realise. So again, and for that reason, we actually do make referrals to Carer Gateway, so they can offer, there's a 24-hour support, but some people use that in 3 lots of 8 hours, especially for overnight care. And there is a 2-week window. The social workers can pop in a referral for personal hygiene from Carer Gateway. It's not 24/7 care, but it's a carer, everyday care for nurses to come in to assist with personal hygiene. So with the ongoing follow-up and handover to the rest of the team, which is what we do daily. And if someone's in a terminal phase, we do visit them daily just to make sure that everything is managed, that everyone's comfortable. We do send an updated fax to the GP and say this is what's happening, he's heading towards end of life. We're having regular nursing visits and social work is provided. So after there are pages and pages of the Banksia on a Sunday evening with deterioration in swallowing, worsening chest secretions and restlessness. So then that's when we've kind of started that subcutaneous medication. So when they're heading to that terminal phase, we call the GP or fax. Monday morning is very hectic for the GP clinics, and we call just to give an update and just to advise of those that terminal phase, like I mentioned before, and we commence that syringe driver with the hydromorphone, 3 milligrams, buscopan 80, midazolam 10 milligrams over 24 hours. So when someone has a syringe driver, obviously we're visiting every day to replace that, but also we draw up breakthrough medication and educate the family regarding that if required. So the GP was happy to provide ongoing care at home. Unsure about the provision of the death certificate because it was 4 months since he saw Mark face to face, even though he did have telehealth appointments. So we do try to keep that contact or that connection with the GP going during this process to hopefully keep the GP also informed of how he is. And then Mark, died on the Friday night. So from Tuesday, the commencing the syringe driver to the Friday night, the Banksia palliative care nurses do attend to the verification of the death, and then we notify the GP of the death the next business hours. So in the way of take-home messages for caring for Mark at home, we really do rely on that GP availability and ongoing support, prompt access to injectable medications, which, you know, there is a bit of toing and froing sometimes in that regard, and then we have to access those medications from a pharmacy and ensure that pharmacies have the medication that is required, because sometimes they're not routinely stocked, so then they might have to order them in. Provision of equipment, increased carer support, social work available, regular palliative care nursing support, and verification of death and the provision of the death certificate. So with regard to Mark, we would consider him as a late referral. We actually like to see people sooner rather than later. We always ask people to think about, do you think this person will be alive in 6 months' time? If the answer is no, a referral would be great. Only because we get to know them, we can avoid rushed and panicked times for the family, and also it can, if we can do the anticipatory actions in the way of medications and equipment in the home, hopefully avoid those unwanted hospital visits or calls to ambulance. Yeah, so some patients are actually with us for many months and up to 2 years, or even more actually. We've had a few up to 5 years, ones that have had neurological conditions. And sometimes we even discharge clients because they're doing so well that they don't really need our service and they don't want us anymore. So the common interventions and medications and practical supports to enable end-of-life care at home. Interventions in the way of palliative care would be regular nursing visits. If they're not visits, they're regular phone calls. And we just assess those little symptoms. Sometimes a little change might be small for a client, but then that would flag to us to say, oh, okay, things are changing. Emergency provision of equipment to assist with care in context and functional deterioration. So the end of life scenario, Banksia cover 6 weeks of equipment hire for families. For example, a hospital bed, the air mattress, over the seat toilet, bedside commode. They're just a few examples. Support from the social worker and family support worker, grief counsellors to provide emotional and social support to patients and their loved ones, and the allied health inputs such as music therapy and massage therapy. So in the way of medications, the RNs and the senior nurses will provide special advice around symptom management medications. The GP remains the treating doctor, so we, might call the doctor and say, look, this Mark is having too many breakthroughs, or not too many, I shouldn't say too many, but he is requiring 5 or 6 breakthroughs throughout the day. Can we please look at his slow release medication? That's just for an example. And again, we will often ask for that anticipatory medication. If the goals of palliative care are for comfort measures in the event of deterioration, having that end-of-life medication at the home prevents those unnecessary hospitalisations and suffering. It just produces so much stress, and we see it often. The thought, even since COVID, it is certainly worse, but it's, the thought of people just have this vision that they'll be sitting in ED for 12 to 24 hours. So if we can avoid that, that's the best outcome. Our palliative care physicians are available for specialist support around complex cases, but not only complex cases, even cases that just need an extra pair of eyes. Would I be fair in saying that, Chen?
Yes.
Yeah.
So yeah, like we discussed before, it's in addition a general practitioner, and in fact, a lot of time, if the patient and family, and sometimes we know they really haven't had a chance to have a GP, especially for young patients, and we do say, look, probably do need to get them known to the local clinic as well, even when we do try to provide support as much as possible in those cases.
Yeah. Yep. Yep. And in the practical supports, like I said earlier, they've got access to the 24/7 phone number with visiting service for just in case those emergency responses overnight. We have enrolled nurses that provide that training for family for the provision of personal care, and also assist in providing personal care for clients who are terminal, because that can be quite daunting for families. And the nurses, the registered nurses, also, as all the staff at Banksia, provide counselling to the family of what to expect at time of death, and to explain that sometimes families are open for those discussions on what to expect and during their loved one's journey, and that we can attend home for verification of death.
So I'll take over and talk about the certification side of things. So just I've put it in the chat as well. So verification is the examination of signs of life, and it can be done by medical officers and registered nurses and paramedics. And when someone's at home, our nurses definitely can pick up that aspect of care, whereas certification does come back to the main doctor. And this is a widely discussed and debated area, probably more so because in suburban Melbourne especially, many people are absorbed into intensive treatment attendances with the hospitals, and simply just never had time to see their GPs until they've run out of treatment options and they're discharged from the hospital without a doctor. There is no other specialty that can take over care. So there are setups like hospital in the home, and but that's not that's less common, if any, in the palliative care setting. And of course, if they do come back to the inpatient palliative care unit, then the specialist service takes over completely medically as well. But for majority of our patients, our clients, at home, even when the community services are involved, we may not have seen them from a specialist, from the palliative care specialist point of view, in that if they may have the specialist nursing needs and every or other support met, and still having the GP involved as their main doctor. So just a reminder that it's more legal paperwork. So it's quite different to a physiological sort of document, and which is why the wording is a bit clunky. So we talked about this one a bit, I think, and but of course, just a reminder that people can go to their funeral homes after the verification is done, and often when we chase out the certification, or when the funeral home chases it up, it is the person's already in the funeral home, and they need to have it before they dispose of the body, so before the actual funeral. So legal purpose for validity of a will or life insurance payment, status and public health purpose, which by the Bureau of Statistics, and to improve health of Australians or family members to know, and also to be aware of conditions that can occur in other family members. And of course, it's to prevent disposal of bodies without professional scrutiny in relation to suspicious deaths. And yes, clearly that's happened in the past. So that's why there is a process like this. Yep. So we're going to go to the next one.
Sorry, yeah, next one.
Yeah. So with this, and in terms of the doctor who is responsible for personal medical care, and that's where we talked about a bit, in that once the person's discharged from the hospital, it is down to the GPs, and we know no one works 24/7, of course, but we do try to identify the primary person, and that's often nowadays in suburban Melbourne the clinic, and there may be a main GP available, but really it falls down to that clinic. And of course, the person who examined the body can also provide certification, and as in the doctor who examined the body, which is why sometimes if no one's really seen the person medically, if people died at home and hasn't been seen by anyone medically, then a medical officer can go out to the funeral home and examine the body and provide the certification that way as well. And it's more in a sense that there's no suspicious, look at the circumstance, make sure there's no suspicion, and that confirm there is a body there before certifying. And the technical time frame is 48 hours, but yeah, we know that in terms of workload and everything, we know there's often delays. So the cause of death, and again, this comes back to it's more for medical legal purpose and less for physiological record. And it's the disease or injury which initiated a train of morbid event that leading directly to death, or the circumstances of accident or violence which produced a fatal injury. So it's really a train of events, and the beginning of the train of events. So when people have cancer or dementia or the major life-limiting illness, we often only put that thing down. But also important to remember if there's any fracture or bleeding, generally we'll need to put in a preceding cause to make it not a reviewable death, basically. Otherwise, yeah, if it's only if people died from an injury, really, there will be a coroner's. Therefore, we often will request the GP to first, and the funeral home certainly will request the GP first to complete this medical certification. And sometimes, if literally there's no one else eligible, then it may go back to the hospitals, but technically they've been discharged from the hospitals, so they're technically not responsible after that. And in some cases, especially in the case where we actually have seen the patient, we may help support that. But most of our patients won't have been seen by our doctors. And if there's no one that can complete it, it is referred to, well, birthdays and marriages first, and they may refer to the coroners.
And along with that, thanks, Chen. The grief and bereavement is, like I said before, we've got 13 months of bereavement support for families, counselling for the individuals and the families. We have carer circles and carer information sessions, education on grief, loss and bereavement. We provide remembrance services about 4 times a year. Obviously they didn't run during COVID, but we're just starting to get those back on normal routine now. And we also have walking groups, which has been proved to be quite popular. So, yeah, the Australian Centre for Grief and Bereavement is a great resource for services and suggestions for family or the bereavement that's available for children, for adults, all different demographics actually. So it's quite good. So we're just going to go on to that prescribing of opioids in palliative care and the role of the GP. We did cover that a little bit, but Jen's just going to go through a little bit more in a bit more detail in regard to opioid prescribing.
Thanks, Wendy. Yeah, so like we mentioned before, we'll go through the opioid a bit more, and we're not covering sedatives and antiemetics and antisecretories in this case, but in the post-event email, we'll be sending out some resources around that as well. So we'll be going through just general understanding of commonly encountered opioids and that the requests you may receive around prescribing, and also the PBS requirements. We won't be covering in detail. In fact, I'll be skipping some slides around molecular and pharmacodynamics, and not covering generally not in chronic non-malignant pain, though of course people with those can be dying as well, and because they don't respond as well to opioids, which in fact means they're more likely to have side effects from opioids. So it can be a tricky space as well. But we'll focus more on cancer pain in this case. So next. Yeah. So yeah. So we talked about this, and so for everyone living at home, even when they're on the community healthcare program, the GPs are the main providers, medical care providers, and we talked about end-of-life care support, which anticipatory medication is largely used for. But also, of course, there are other reasons people might not be able to take their medications orally, like in nausea, vomiting, for example. And if we have injectable medications, then we can make sure people don't withdraw from what they need for their cancer pain, or potentially escalate for acute symptoms. And so cancer pain is the big one. Sorry, previous slide. I think we've done to, yeah. Breathlessness is, yeah, that's right. Breathlessness is another common indication that we use opioids for nowadays. So yeah, just a very quick Cook's tour. So opioids act on opioid receptors, and that's why they're called opioids as a class. And strong ones, or in fact, they're simplish ones, the morphine, hydromorphone, and fentanyl. Methadone is strong, but it's a full agonist, but it is a bit more complex pharmacokinetically. And some of you may have methadone licenses for opioid pharmacotherapy or opioid replacement purposes. That's very different to how we use them in this instance as well, but of course may need to be reviewed when people have new cancer pain. So weak opioids are nowadays includes tapentadol, codeine, buprenorphine, and tramadol. Weak as in because they're not that weak, actually. So generally, we say to use strong opioids in small doses and avoid the weak opioids because that's more predictable. And the weak opioids often they're either partial agonists or like codeine, it relies on some metabolic intrinsic ability to convert it to morphine for it to work as a pain relief, which is why they're not very predictable. And if we know people, especially in cancer pain, will need to have opioid to manage the pain, then it's simply easier and safer to use strong opioids but in smaller doses. In terms of background dose and breakthrough dose, so I think of them as preventers and rescues, basically. So if we know someone will have ongoing pain, then at some stage they will benefit from working out what the minimum effective dose of background dose is. And that's not to cover all the breakthrough pains with the background formulation, because of course when they don't have a breakthrough pain, that'll be too much. So the dose of to cover breakthrough pains often is quoted as 1/6 to 1/10, and that came from the duration of effect. And it used to be, before we had slow release formulations, before people used to get morphine every 4 hours, because that's how long they last, which is why a dose of, we generally think people can tolerate another 1/6 of the dose. But there has been studies that showed, in fact, down to 1/10 or 1/12, it will still be effective for breakthrough pain. Saying that, though, of course, if it's not effective, we should be increasing it. So it's not that everyone should be on 1/10 or everyone should be on 1/6, but it should be titrated and potentially independently, depending on what the breakthrough pain is. Because sometimes if it's an incident pain, like, for example, bone pain on weight bearing, they may need much more pain relief during personal care, and as compared to however much background they are on, because 1/6 may not cover that incidental event. And one other main message is make sure they have laxatives. Will I keep going?
Yeah.
So that's just a graph for background and breakthrough pains. And there's also a little note of end of dose failures, as in if medications are thought to last 12 hours, or in a case of patches, 3 days. And we do notice people report they have less efficacy towards the end of the dose. And how people respond to that is different. You may see some clinicians recommend more frequent dosing, but of course the other way is to increase the dose if they can tolerate it, and so it doesn't drop to the level where it's ineffective for their pain at the end of the dose. So people with moderate to severe pain from cancer, 19 out of 20, so we can reduce it to with tolerable level or even no pain within 2 weeks, and provided we're managing the side effects. And the big one is really constipation that we need to manage. So when we say most people have side effects, constipation is generally, if I would say even everyone will probably need to work out a laxative regimen. And that's not to say it's all opioid related. In fact, there are a lot of factors that slows down the gut in this setting, and that's why even without opioids, they often will need a laxative regimen anyway. Nausea, vomiting is common, but often will settle after a day or two, once people get more used to the medication. And but 1 to 2 out of 10 will require actual change in opioids, and that we're talking about opioid rotation. So more often neuroexcitatory problems, like hallucinations and myoclonic jerks, and in worst case scenarios, opioids can cause seizures and hyperalgesia is another terrible effect to have. And those are situations where we generally have to change opioids. So the drowsiness and the nausea and vomiting often transient and often improves within a few days. And sometimes with the drowsiness and fatigue, sometimes that's a balance, because of course, I often say to people, pain itself is tiring as well. And also that there are many other reasons for fatigue and drowsiness in this population, and it may not be overall avoidable with or without the opioids. In terms of allergy and expected side effect, so we quite often see nausea, vomiting listed as the reason they're allergic to an opioid, and of course we know that's not histamine mediated, and people won't actually go into anaphylaxis from these. So other things, the constipation we talked about, but anticholinergic things too may need watching out for. Urinary retention is not super common, but it's certainly something we need to keep in mind for especially those at risks already. And we talked about the neuroexcitatory ones that often we do need to rotate opioid for. Respiratory depression is not common, and because generally dosing is that we go with are fairly safe, and if there's any, in fact, people develop tolerance quite quickly. So it is extremely rare to actually die from an opioid overdose in this setting, and which is also important to remember that because sometimes we'll touch on the wish to hasten death and desire to die, and one important message is that opioids are not a great medication to use in those settings. So we generally start with as required, and if people have regular breakthrough pain needing regular doses, then that's when we introduce the background and up titrate slowly based on requirements and tolerability. There's technically no upper limit. Saying that, though, more than 100 milligrams morphine equivalent, we know people are more likely to have side effects, and that's when we start keeping an eye on whether we need to start introducing more opioid sparing measures. And that's the big difference between cancer pain and many other pain, in that because we know opioids likely need to feature significantly in cancer pain, we don't introduce things like pregabalin or amitriptyline or other opioid sparing until we know that it's definitely not working / causing side effects, which is essentially two sides of the same coin. Whereas, in non-malignant pain, or even other factors like neuropathic pain and incidental pain, we know they don't respond well to opioids, and we may introduce the adjuvants a lot earlier. So we're going to go through the different opioids very quickly. So and I probably wouldn't talk about the contents of these slides, but the morphine, oxycodone, and hydromorphone are the ones that has very similar pharmacokinetics, and morphine is the gold standard, and all the studies are essentially tested against morphine, and which is why every time we do opioid conversions, we convert to oral morphine first. And the main downside of morphine is it can have neuroexcitatory metabolites that's dependent on renal clearance. So people who have renal impairment are more likely to have neuroexcitatory side effects from morphine than oxycodone and hydromorphone. So that's the main limiting factor. And often, if people's eGFR are less than 30, we will consider using oxycodone or hydromorphone first. Fentanyl, very pure, so it doesn't have any neuroexcitatory metabolites, so it's very safe in renal failure and other organ failures. On the other hand, the pharmacokinetics is very challenging. As an immediate release formulation, it needs to be absorbed either transmucosally or as an injection, and they last very, very short, so 1 hour max. And the thing is, that might be useful for incidental pain, especially when people are saying, oh, when they have pain when they do something, but then they take their endo prior to doing it, and they get knocked out for too long afterwards. So that's the classical example where we might say, okay, we might try some sublingual fentanyl, and that only lasts an hour, and that might be enough. So that's the classic example. Sometimes it's touted as a faster onset, but really it's not that much faster than the standard opioid in terms of onset time. So the short duration action is probably its biggest draw card. And we know they come in patches as well. Patches takes a day or two to reach steady dose, and it really is not predictable enough, because the absorption also depends on your body fat. In fact, if you're too skinny, you may not be able to absorb the patch into the subcutaneous fat and end up underdosing. So it's just very unpredictable. Methadone, in this instance, it's not used for opioid replacement or for pharmacotherapy. It's itself, because it works on NMDA receptors. So in fact, that can treat opioid hyperalgesias and other pain when there's refractory to simple strong opioids. So it's relatively safe in renal failure because it's not dependent on renal clearance. Its metabolites not all that neuroexcitatory, and but because its pharmacology is very tricky, it's non-linear. You get a little blip for about 4 hours, 4 to 6 hours after you take it, but then it doesn't, and then it sort of stays in the system and can accumulate sort of for 3-5 days, sometimes even longer. So for all intents and purposes, it's probably more like the slow release medications, but more because it accumulates and remains in the system. Generally, we would be also involved to help titrate and monitor the situation, and we wouldn't leave it up to the GP clinic themselves, by themselves, generally, with the methadone. So, and the last quick one is I'll talk about is the Targin and OxyContin. And because Targin, as you know, essentially is oxycodone plus naloxone, and it's a good measure to reduce constipation. Although, like before, we talked about how people often are still constipated, and they need to work out how to use laxatives anyway. They may need less, but often they still need to work out how much they need. Two is, the other thing is, it can be a problem in liver failure, because if their liver is not working, it's not removed by first pass metabolism, and it can actually antagonize analgesia, which is why often the first thing we do is actually when people are on Targen and their pain is worse, and rather than increasing the Targen, we may actually switch to OxyContin, and sometimes we'd even need to drop the dose just to remove the unpredictability of the naloxone, and because we don't know how much naloxone is actually entering the systemic circulation, so we might need to use less oxycodone at the same time. So, it's just less predictable than OxyContin in practice, and something we need to be mindful of. So we talked about avoiding weak opioids in cancer pain, and rather we just use a smaller dose of strong opioids because of predictability. Saying that, though, of course, if in non-malignant pain, or if we have other reasons for opioid sparing to start with, we might actually introduce them or use them. Very rarely we introduce them. We generally run with it for a little while. If it's working, probably it's more common. We generally don't use codeine because it's super constipating. It needs to be turned into morphine by the liver to work as a pain relief, but the full codeine is fully active as a constipating agent in the gut, so it's really not that useful. Tramadol, because of its serotonin action, it actually has potential to cause more delirium than simple strong opioids. So that's something we also rarely use. And tapentadol has less serotonin action, so it's more a noradrenaline reuptake inhibitor than the serotonin one, and slightly less risk, but again, not very predictable. So we might skip these ones because for the purpose of today. So the opioids and dyspnea. So we have majority of evidence is morphine, and it's not that much evidence, and it's actually quite tricky to get right. And the evidence is that sustained release morphine up to 40 milligrams, I would argue even between 20 to 40 probably is the range, because we already start to see increasing side effects between 20 to 40, and certainly there's nothing to justify more than 40 milligrams on the population level. But of course, if case by case they're tolerating it and not getting side effects and reporting benefit, it's not to say we don't use more, but it won't be in evidence-based category. Again, when we talked about opioid responsiveness, it really is relieving the symptom without causing side effects, and that's what we're talking about, is that people experience relief of short breathlessness. So they do say they feel less short of breath when they're taking the opioid. So the catch with breathlessness as well is often breathlessness are incidental. So which is why we often talk about perhaps just try some immediate release opioid prior to your exertion. Classical example is showering, and but it's also important to remind patients that, in fact, people aren't able to exert more after they take opioids. It's more that they feel less short of breath, and potentially they still need assistance with it. And often we see people complain of shortness of breath, even when the family or nursing staff are helping them with the shower. And we say, okay, maybe we give some opioids prior and see how we go. rather than promising, saying, oh, suddenly, if you can't shower before, take the morphine, therefore you can shower. That's generally not the case. So, and the background opioids is quite hard to judge in this case as well. So, and quickly talking about the barriers to appropriate opioid use. So it's often, there are multiple factors, and there are clinician-related factors, and we know there's a lot of rules and regulations around opioids, not really for the palliative population, but more for the rest of the community, and patient-related ones as well, in that there's often fear of what it means to need more morphine or need more opioids or simply have more pain. So there are also other background cultural issues with fear of opioids, especially in Southeast Asia, where opioid trade has been an issue historically in the past. So we often do need to proactively address these, because of course, if the pain is preventing people participating in activities of daily living, then yeah, the people will do better if they manage the pain, and often with cancer pain will be with opioids. So and we do need to talk about that. No, they don't hasten death in this setting, and they need to be addressed. They are used at different stages of disease, not just the end, and that actual addiction is very unlikely in this setting, or development of new addiction is extremely unlikely in this setting. Again, tolerance as well is unlikely. Saying that, though, we certainly can rotate opioids if anything becomes less effective. So there will be conversion sort of resources that we'll send out with the
yeah, on safer care.
Yeah.
Yeah.
So we'll keep going.
Yeah.
Yeah, keep going.
Yeah. Okay. And that's the conversion again.
Yeah. Yeah, keep going. We talked about that already.
Yeah.
Oh, we kind of talked about this already, I think.
Yeah,
so.
yeah, we did. Yeah.
Yeah.
Keep going.
Yeah, we talked about this. Yeah. So to talk about the PBS and the safe script requirements, so palliative care technically, and cancer pain, in fact, people are exempt, and you do not need a permit. And in fact, you also don't need to have safe script, provided that the person hasn't been identified as an opioid dependent person in the past, or I suppose currently. But if they've had a history of it, then the prescriber need a permit. But otherwise, if it's for palliative care and cancer pain purposes, you don't need safe script nor permit. With safe script in place, as long as you check safe script, there's no formal permit requirement either. And just to confuse things, but yeah, but technically you don't need either for palliative care purposes. People do worry about ongoing supply of medications because it is hard. They don't want to be seen as drug seeking. Medications do run out, and often they reach the community palliative care. They have limited mobility and can't get to the doctor. So we do ask people to make 3 weekly appointments with GPs to have medications prescribed for the following months, and of course it can be a bit of a task from the prescriber's perspective, but just to reassure people that if they're on the community palliative care program, the nurses keep a very close eye on opioid use in the household, and you will know straight away if there's any concerns around supplying increased quantities. And we do recommend supplying monthly quantities when people are stable on their dose.
We went through that.
Yeah. So if they're terminal, we often recommend do 1 week's worth and then do repeats, so they don't end up with 4-week supplies of injectables. And we do talk to the family about returning anything not used to the pharmacy for disposal. And they're often streamlined authorities for increased quantities. But for monthly supplies, often you will need to do a formal approval. Yep. Okay, keep going.
Yeah, so we've got another case study. I'm not sure. Should we keep going or?
Yeah, I wonder whether, just in view of time, whether we go straight to the next topic, because we had a bit of a case before already.
Went through that before.
Yeah, this one's a bit more involved, and
this one's more about the opioid conversions and the breakthrough doses. So do you want to start with that one, Chen?
Yeah, so we can.
Yeah, so it's just, yeah, we'll move on just because of a time factor. And the previous other case study is pretty well a repeat, just a bit more in depth of the previous one. We're just going to look at the conducting of essential conversations with palliative patients or clients and their carers, which can be really, really tricky. So, you know, we'll have a look at the disease trajectory and care, which we'll probably skip through a little bit, but the informed consent to palliative care. We always, first thing we do is we rock up with our consent form for the clients or family to sign up, because they, you know, that's a legal document. Palliative care and human rights. Everyone has the right to best possible palliative care, terminal phase changes, advanced care planning, and the wish to hasten death, which we do get confronted with at times.
So I often start with this quote, and understandably from our neurology colleague, that that CPR is a treatment for cardiopulmonary arrest, not a treatment for dying. So, of course, if you're dying from a stroke, then no amount of CPR is not going to help. But really, for a lot of our patients, we know whether they will respond to high burden treatments like CPR. And you may see, I'm sure you've seen graphs like this before, and we know there's a decline in function, and people have dips in between, and we never know when the last deterioration is the one that's going to lead to the death. So, which is why it's important to set the scene, and it is the clinician's responsibility, and arguably the medical clinicians, because we're the one that that offers the treatment, to talk about that the knowledge that we have, that the patient's chances are that don't have, that some simply won't work, and some are very burdensome, and people isn't gonna be able to recover to an acceptable lifestyle even with the treatment. So we should not be offering or continuing any treatment that's non-beneficial, and we should ensure their symptoms and care needs are managed. And by limiting non-beneficial treatments, then allows everyone to focus on the right care at the right time in the right place for that person. So, of course, spending time dying in ICUs won't allow you to spend time dying at home, simply put. So this is a graph of when end-of-life care is defined, is in the Victorian system, in that it's defined as the last 12 months of life. But we all know there's plenty of different care preparations like advanced care planning, and often some low burden curative restorative care can continue. And we know palliative care can start when it's mainly curative restorative goals, but will need to increase towards when people are not recovering. We know assisted dying is in legal in many states now, and that's certainly something people consider as one of the options. And then there is what we call terminal phase care, which is when people are in their last hours to days of life, and often they're unconscious. We need to there's some very specific personal care needs and symptom needs, and as well as it needs to inform family and funeral directors and other post-death care providers, and before we transition to the bereavement phase. So common challenging questions. So this is where I'll call upon Wendy, and we'll share how we respond to these questions. But any of you feel free. I'm sure you've been confronted with some of these as well, and feel free to jump in and talk about and type in your responses as well. So and you know, quite classically, we walk in, we will hear people say we want everything done, or there must be more treatment that the person can have. Shouldn't they be in hospital for antibiotics and IV drips? And can we at least give fluids in the subcutaneously? So how would you respond to the family, Wendy?
Well, we often, and this comes up all the time, so we often talk about we start to talk about the quality of their life, what their loved one would possibly want, or and if in that scenario they did go to hospital, what potentially would that outcome be? So the difference between, you know, going to hospital and not going to hospital, does it give them another 1 day of life, or 2 days possibly, with the potential of transport to hospital and dying in an ambulance or during transport, and not at home? So we do, of course, it depends on the situation and the family that we're talking with. It's really trying to get the bigger picture rather than dealing with the current situation, which is tricky because everyone's emotions are quite heightened. So and it's an emotional time. Yeah, and there's never any right or wrong. You just have to do the best you can with where you are at the time. People do ask if we give fluids in the home, and you know, often they get disappointed, or they kind of, sometimes they know the answer but they ask anyway. I've been guilty with that with my own loved ones. So it is just tricky, and we just got to talk about the pros and cons and quality of life. Has anyone else got anything to add?
So I was just going to put my 2 cents in.
Yeah, sorry.
That's all right. Yes. I think there must be my echo rather than someone else trying to speak. And yeah, look, I think validating that wish to trial treatment is important, but also also explaining that again, the option of focusing on the care, I think is usually how I term it, and to explain that look, there's a very high chance that if there are at the close, you know, at the pointy end, really, there's a very high chance that further investigation treatments is not gonna make a difference anyway. And you know, if they're low burden, if we're just trialing something oral, like a course of oral antis at home, that's fairly simple and fairly easy to arrange. But we're talking, you know, transfer to hospital. People can something can happen on the way, and people can easily have adverse effects from, you know, higher burden treatment. And it's important to know the different options. Basically, the other thing I often remind people is that it's not that we're not doing anything, but in fact we need to do more. We need to provide the care that person needs. So and the treatment is not care. It's if you can't fix the problem, then providing more treatment really is not a good thing. And all treatment comes with its own burdens as well. So we'll touch on the fluids and food a bit as well, but again, we talked about discussing limitation of medical treatment, and not starting is arguably one of the simpler aspects. CPR is the poster boy. Stopping preventive ones, usually simple, although people can get quite attached to their statins and blood pressure tablets. But yes, stopping maintenance treatments is quite hard. So we're talking about stopping dialysis, stopping NIV, and those are, you know, those can be quite tricky decisions and discussions to have. And back to trial treatments, is that important to set limits, as in, look, we can, if people are really keen to trial some antibiotics, to say, okay, if we're only going to do a 3-day trial or 7-day trial, and really if there's any side effects, or if the person continues to deteriorate or just not improve, and defining what improvement is. Because of course, if they're still breathing, it doesn't mean they've improved. And there really needs to be some functional recovery to be aiming for at this stage generally. And in terms of legally, we're not compelled to provide treatments that's deemed non-beneficial, but we should be offering a second opinion if that's not already been given already. So and Bad Health Channel does recommend to the patient that they can seek a second opinion if you're unsure about the treatment and diagnosis. So, of course, and sorry, I know these are your slides, Wendy, but
sorry.
But I'm happy to. You're happy for me to just yeah. So it's important to talk about their wishes for inner life early rather than later, and important to document their choices of care and initiate a conversation with the health professionals, because they do need to be witnessed by doctors. And health providers should initiate honest, timely, and culturally sensitive conversations, so they are a routine part of healthcare delivery.
We often get these situations where someone wants to talk about it, but the other person doesn't want to talk about it. And let's not talk about that, but we kind of need to talk about it. So it can be really hard, and we do have often people saying, "Oh, don't tell Mum you're from palliative care. You're here to support us," or "Don't tell them they're dying." And I know there are cultural and other issues there that are associated with those choices, and that's fine. So, but we support that. We don't go against that, obviously, but they're those things to navigate and just ensure that, if you can, people are on the same page. We do find that, and our social workers would actually vouch for this as well, the more the open discussions that are had and the more awareness and insight of what's going on, the better the palliative care outcomes can be for the client and the family in the way of predicting what treatment and end of life, and there's no surprises. So even though those conversations can be quite difficult, it often does provide better outcomes in the long term. And then even with regards to advanced care planning, when the person has died, family have relief or ease of mind, that peace of mind that everything has been put on the table and discussed. Yeah. So yeah, these little cartoons about you only get it right once, but yeah, it's easier said than done. We're totally well aware of that because we see it every day here in every home. So we try to support that as much as we can, and that attends again to those early referrals, because often if we have an earlier referral, we can start to kind of plant little seeds in having these discussions before the pointy end. And it makes a huge difference. We see it when people have had open conversations. The journey is calmer, I guess. Yeah. So there are quite a few resources in the way of discussing, prognosis and end of life care issues. There's actually lots. Advanced Care Planning Australia have done a big media release this year. They've had the movie Live the Life You Please, which has been quite good and shown throughout Australia. So that's worth a look in. I think we actually put that link, that information up. It's worth watching. So with the advanced care planning, a 2017 study assessed how many people aged 65 years or over had at least one advanced care directive on file, and 48%, the people that did, the 48 were in residential care. I think when people go into aged care, they're often supported to get encouraged to do it as soon as possible. 16% in hospitals and 3% in general practices. We could do better with this. And then even not everyone has a substitute decision maker or a medical decision maker, medical treatment decision maker. Again, that's really important. And again, we see that when we're dealing with people at palliative care, people don't really think that I think they assume that they're always going to have this ability to make these decisions, but we don't have a crystal ball and we don't know. But again, that's talking about things that people don't necessarily want to talk about. So you can go through advanced care planning through their website, or even go through Solicitor and grab forms online and go to the GP and have discussions. That's obviously a planned appointment, that's to have those conversations. But sometimes, the GP could possibly say, have you thought about this? Maybe have a think about this, make an appointment in a few weeks, make it a double appointment or something. And then it might be something that you'd think about and discuss next time if you plan to proceed. And also, and those are great for those refusal of medical treatment. You know, and it is based on people's values and they're informed, their wishes.
So yeah, so just very quickly talking about the law. The thing about putting things down, one is of course to substitute the decision maker if they have anyone else in mind other than the person highest on the hierarchy, and so if then they writing it down will be the safest, and but of course it does depend on who's available and the willingness to participate of the person as well. But the other aspect is the instructional directive that people can refuse treatment in advance. They can't technically, people can't request treatment, so people can't say, oh, you know, when I'm dying, please ventilate me. If and health professionals are not bound by provision, but if it's deemed non-beneficial. But on the other hand, health professionals are bound by not providing something that the person has refused. So, so if we're aware of a legally valid refusal of treatment, but written down as an instruction directive, then we have to take it seriously. So the next bit is informed consent in palliative care, and the classical questions we get is, please don't tell my dad that he has cancer, or don't tell my mom you're from palliative care. And Wendy, how do you respond to this?
Yeah, again, look, we in the end, we acknowledge and support that in the household. Like we if someone says, don't tell my mum you're from palliative care, we're going to say, hello, I'm a nurse, to come and check on you, and to see if your family need any help. We don't necessarily, we might say we're here to support you, but we honour that wish for the family. So we don't go against their wishes. Again, same with treatment and cancer. Oh, sorry, if someone has cancer, generally we find that the actual person who has the condition know anyway. They kind of get an idea of what's happening. They just don't want to verbalise it. So we do, yeah, we do support the families in that regard. It's not our role to go in there and tell them how to live their life. We're just there to support them. How do you do it, Chen?
Yeah, I agree. I think
probably worse for you actually, because you're the doctor.
I think again, we don't have to talk about the actual disease as long as they're consenting to the care provided, because really we're not there to treat the cancer. We're there to make sure the person's looked after either way, really. So in terms of talking about whether we're from palliative care or not, similarly, I think if they're consenting to our involvement, but not necessarily wanting to talk through more, then that's not something we have to jump up and you know and parade around. On the other hand, you know, if we're gonna give analgesia, and we do need to make sure they know it's you know, if we're giving opioids or morphine, we do need to talk about that.
Yeah, talk about what it's for.
That's right.
It does depend on everyone's idea of what their idea of palliative is.
Correct.
Because then there isn't, most people still, like even at the conference, palliative care, people still think it is the last few days. So as soon as you mention the word palliative, they, you know, the red lights go on, and so it's educating people and the family that it's a long-term thing, and I guess it's the term. I think it's the term that people are afraid of more than anything else. The actual word.
Yeah, there was a joke about how we're from the palliative scare unit, and yeah, and look, it is an opportunity to talk about actually palliative just means to relieve. Doesn't imply anything, and that we are here to you know, what we talk about is we hope for the best and plan for the rest, really.
Yep. Yep.
So very quickly, we've kind of whizzed through this already.
Yeah.
That people can refuse treatment, and that we usually need to seek consent for treatment, and capacity to consent assumed unless there's, you know, proof otherwise. So on the other hand, we can actually give palliative care if someone's already lost their decision-making capacity, and we should inform the substitute treatment decision maker where possible, and also have regard to the preference value of the person if it's available in the values directive or otherwise. In that, palliative care is not quite defined as, so it doesn't mean we can give morphine and sedatives because they've lost capacity, because it still needs to be justified. It is the care that we can provide. Do we have a So the other thing that's often come up is people talk about you're just starving, dehydrating the person to death, or whether we're killing the person with morphine. And so that's very common. Wendy, do you have your response to that?
Yeah, we do. Well, with the killing them with morphine, we just explain that it is treating the symptoms, and we talk about you know, what it'd be like with or without the pain, the analgesia, or medication required to keep them comfortable. And you're starving and dehydrating to death. We do hear a fair bit of that, unfortunately, from families when they're with their loved ones in aged care facilities. And we support the family and just say it's not the starving or dehydration or lack of food or fluid that is killing them. It's the disease or their their decline in deterioration that they're dying from. So we try to rearrange the thinking a little bit. That's what we would do. Yeah, it's quite common, unfortunately.
Yeah. So should we, in terms of, I mean, how I would explain things is often I talk about how it's the result of the body deteriorating rather than a cause.
Oh yeah, sorry. Yes.
Oh no, it's okay. And everyone has a different answer, and I found that that's worked for me a few times, and that just reminding people that if we put people can't tolerate the food and fluids as well at this stage, and often if we put it in parenterally, often they end up in wrong places, and people have pulmonary edema and lower limb edema and other edemas, and so it's not something that that we would recommend generally when the body's not requiring them in the first place. In terms of, and it often gets brought up because we know offer of food and water and clothing and shelter is human right, but we're talking about gentle assistance and not invasive feeding and fluid. pain relief is also, and other medication for distress is also human right in this context. Keep going. So another part of the law is that we can actually give treatment. So this is not palliative care specific, but any treatment without consent if we have reasonable grounds to believe that the treatment is in a matter of urgency to save the person's life, prevent serious damage to the person's health, or to prevent the person from suffering continuing significant pain or distress. And in palliative care, that's easier to justify as they may be in the last few days or hours of their life. And if they have pain, that is, they're going to have pain for the rest of their lives, essentially. So, that is also something there to protect the clinician, to ensure comfort of the person. And that's not, as we talked about before, opioids rarely is able to hasten death in this setting, and and it is used if there's pain. So that's okay. I might whiz through these very quickly. Sorry, Wendy. Just looking at the time. So
okay.
Yeah, but if we go back to the previous slide.
Oh, sorry. Okay.
So this is quite common because when people are unconscious, the breathing gets louder, and often family will talk about, the person is drowning or choking or suffocating. Delirium is also quite common, so people say they keep calling out and getting out of bed, they must be in so much pain, and but also get concerned about people being repositioned, and every time we do so, they get so much pain, and so we're giving too much painkiller so we can turn the person. If you go to the next slide. So just a reminder that everything's distressing for the grieving family. Delirium's common, but important to remember that opioids are not reliable sedatives, and benzodiazepines, antipsychotics, are more effective for agitation, restlessness. The way I think about it is pain is often restrictive, whereas agitation often makes people restless when they move around. Respiratory changes, again, common. I used the analogy of snoring, and it's secondary to loss of consciousness, is not distressing. So when we're not talking about people with MND or other head and neck cancers who have respiratory changes before they lose consciousness, that's different. But if it's secondary to loss of consciousness, we don't believe it's distressing. Cool peripheries is from reduced perfusion and not directly related to sensation of temperature. And unconscious people loses the sense of time. May seem long or short for the family, but not the person. The skincare is important, and it is reasonable to use NRGs as sedative pre-care, although it is a balance. I mean, if there's a hip fracture or other sort of more quite clear, unpreventable pain during care, then we do need to work out what's the minimum effective routine to make sure we also prevent pressure injuries. And just a quick sort of joke that we had from patients in the past that why do you need doctors from palliative care, and don't you just give them more morphine? So just to go on to I think the final scenario where a lot of people, especially nowadays, talk about wish to hasten death, and that whether they can have assistance in that, and whether that they just whether they can have more morphine, because that's of course the poster boy of end of life medications. But we'll go to the next one. So again, just to remind people that opioids and benzodiazepines are not reliable lethal agents. We shouldn't use them, and again, because we can have side effects from them. We know the substances used for assist dying are not opioids and benzodiazepines, and exactly because of that. It's important to remember wish to hasten death is not the same as desire to die. It's a manifestation of desire to die, and people can say, oh, you know, they're not finding meaning, they don't want to live any longer, but that's not the same as asking that for assistance with that. So so it's important to distinguish them, and also must be distinguished from acceptance of impending death and wish to die naturally, although preferably soon. So essentially, wanting to die doesn't mean they want your assistance with it, and of course it's quite a common feeling that people, especially when they are not able to do things they used to be able to do, they have that loss of sense of meaning. And palliative care intends to neither hasten nor prolong death, and palliative care, Banksia isn't participating in the administration of voluntary assisted dying, and will maintain boundaries as permitted by and defined by law. And but of course that doesn't change the access of and decisions around VAD doesn't affect the provision of care from Banksia, and we will provide information for people to access VAD if they bring it up with Banksia.
So just referring to community PAL care services, I will go through this quickly. The best really is to go through to the Northwestern, the PHN, or Palliative Care Victoria Service Finder. There's a link. You pop in your postcode or suburb, and it will come up with the palliative care service that's closer to your area. I went through that before. So Melbourne City Mission is covers the Hume, Marybeck, Darebin and Yarra area. Mercy Health, and there's EPC, Eastern Palliative Care as well. So the best thing is really just to go to Palliative Care Australia, and they will assist with, yeah, you'll find out all your information there. Do you want to add anything to that, Chen?
No.
Yeah.
I think go to the website, Palliative Care Victoria website, and then there's a service finder near the person, and enter the postcode, and you'll be able to find who the community palliative care service is.
Yeah, okay. Dan, did you want to go through the health pathways?
I might just go over this slide. So I just wanted to draw people's attention to health pathways. So for those that don't know, it's a clinical management and referral tool. And you can get access to that through either Northwestern Melbourne or Eastern Melbourne PHN. So it's a clinical guidance tool and has all of the referral pathway information as well. There are 42 pages and sub-pages on palliative care. So there's some highlighted on the menu to the left there. The search bar at the top, you can just put in palliative care and it will take you to the palliative care overview page with all of those pages listed. So that's just a easy kind of one-stop shop for a lot of this clinical information if you want easy access to that. So I will share more details about health pathways in the post-session email if anyone doesn't have a registration for that yet. So you can skip forward a few slides. Thanks, Wendy.
Okay, so just
yeah,
there's some resources there.
Oh, sorry, there's a recording on there that's going to play. You can just keep skipping. It should.
Oh, right. Okay.
Yeah.
So there's a good one actually for symptom control, because they're, you know, really good resources to look at with particular symptoms. And I guess that's how you
Yeah. So you can just go to melbourne.healthpathways.org.au or email that info at address to register, or as I said, via both PHN websites, we'll have a link to health pathways as well.
Yeah. And then you've got the resources for CPD?
Yeah, so just wanted to let people know. So you'll receive attendance certificates for this. We'll send out a post-session email that'll have a lot of those resources that Jen and Wendy have referred to, and as well as the slides and a link to the recording. We also have other useful resources on the website. We've got some quality improvement templates that can be used for other CPD hours, measuring outcomes and reviewing performance if you're needing those towards the end of the year. And we also have a couple of other web pages. So we'll package all that up in the post-session email so that everyone has access to it. And I also just wanted to flag that Banksia are also working with Eastern Melbourne PHN across a lot of these topics, but in more in depth. So across 5 sessions through October and early November, they'll be going into a lot more detail. So if this has piqued your interest and you want some more details, you can go to their website or scan that code to register for the first session and follow on the rest of the series.
So yeah, just some acknowledgement that, with being able to put together these type of education with a lot of help from Banksia personnel, so Tamlin, Michelle, and Lisa, and as well as a few other colleagues from Eastern Palliative Care. And of course, Jen, thank you very much for the opportunity for presenting to this cohort. And yeah, just an opportunity for people to ask questions if they would like to now, but also feel free to email, and we can correspond additionally, or just give us a call anytime. We're very happy to support. Again, if your patient is from other areas or the other community services, I'm all very keen to hear from you. If you have any been confronted with any challenging situations and need some more support.
Has anyone got any questions? It's a bit late now, isn't it?
There aren't any in the the Q&A box. So
yeah, there was one before from the about financial power of attorney and enduring guardian. So I did answer that in text. And, yeah. So essentially, financial power of attorney has ability to make lifestyle decisions for the person, whereas appointed enduring guardian acts both as that and the medical treatment decision maker. But typically, we're more involved in the medical treatment decision making aspect, and that's the one we need a doctor to witness. Whereas the financial one, it's a separate appointment.
Another factor that increases stress in families.
Yes.
Great. Well, thank you both. That was a really comprehensive and informative session. So thank you both for your time and your expertise. And yes, just if everyone can keep an eye out for that post-session email, and please do reply if there's anything else that you're seeking information on, and if you can complete the evaluation survey to help us identify other learning opportunities and topics that you'd like to hear about. So with that, we'll call it a night, and thank you.
Thanks, everyone.